Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Lina Mohammed, your host for today's episode, and I'm joined by the one and only Malak Hassan.
Hey everyone, I'm really excited about today's topic. We're diving into the pathologies of the uterine cervix. There's a lot to unpack here, but we'll make it easy and clear for all of you to follow.
Alright then, let's kick it off with a case.
A 24-year-old woman comes in for a routine gynecological checkup. During the pelvic exam, her doctor notices a reddish area around the cervical os. The patient has no other symptoms.
Okay, so a reddish area on the cervix, but she's asymptomatic. Could this be an erosion?
Exactly. What's happening here is called cervical erosion, specifically an ectropion. It's when the normal columnar epithelium that lines the endocervix extends outwards and replaces the squamous epithelium on the ectocervix. Because columnar epithelium is more delicate and vascular, it looks red and inflamed.
It sure does sound scary when you hear erosion, but it's not cancerous, am I right?
That's correct. It's completely benign and has no malignant potential. It's simply a physiological response to stimuli like hormonal changes, chronic irritation, or inflammation, like chronic cervicitis.
And does it just stay there or does it change over time?
Good question. Sometimes it resolves spontaneously, especially if the underlying irritation or hormonal influence goes away. Otherwise, no intervention is usually needed, unless it's causing symptoms.
Got it. Now, what about squamous metaplasia? I always hear those two together.
They're very closely linked. Squamous metaplasia is when the body responds by replacing that columnar epithelium with new squamous epithelium. It happens at the squamo-columnar junction. The new squamous epithelium is tougher and better suited to handle friction and acidity than the columnar epithelium.
And is that good or bad?
By itself, it's totally benign. But, and this is important, the newly formed squamous metaplastic epithelium is the area most vulnerable to HPV infection. This is where dysplasia and later malignant transformation can start.
So, it's not pre-malignant by itself, but it does set the stage if HPV gets involved.
Yep, you're absolutely right. Alright, moving on. Imagine a 45-year-old woman who comes in complaining of occasional light bleeding after intercourse. On exam, a soft, small, pedunculated mass is seen protruding from the cervical os.
That sounds like a cervical polyp.
Spot on! Cervical polyps are benign, inflammatory proliferations of cervical mucosa. Most arise from the endocervix. We call those endocervical polyps, and a few from the ectocervix.
And what exactly are they made of?
They are essentially an overgrowth of benign stroma covered by epithelium. That epithelium can be columnar, stratified, squamous, or even a mix of both. Inside the stroma, you'll often find thick-walled blood vessels, fibrous tissues, and some inflammatory cells.
So, a polyp is essentially just a benign stroma covered by epithelium. Sounds harmless?
Exactly. They are not true neoplasms. They may cause spotting or postcoital bleeding, but removing them is simple and usually curative.
Now, on to our next case, cervicitis.
Let's think about a 30-year-old woman who presents with vaginal discharge and mild pelvic discomfort. She recently finished a course of antibiotics.
Interesting. Antibiotics could change the vaginal flora, is that right?
Exactly. Normally, the vagina is dominated by lactobacilli, which produce lactic acid to maintain a low pH under 4.5. This acidic environment suppresses the growth of other potentially harmful organisms.
So, when antibiotics wipe out the lactobacilli, the pH rises, and then other organisms could take over.
Exactly. And that disruption can lead to cervicitis or vaginitis. Now, when we're talking about cervicitis specifically, which is inflammation of the cervix, it can be non-infectious or, well, infectious.
Alright then, let's start with the non-infectious cervicitis first.
Non-infectious cervicitis, sometimes called non-specific cervicitis, is often asymptomatic. When you look at the cervix, it appears red and swollen. It's usually caused by chemical irritants like douches or mechanical irritants like tampons and diaphragms.
And how would that look like under the microscope?
Histologically, you'd find inflammatory cells, neutrophils, plasma cells, and lymphocytes, all of that sort. Which makes sense because this is an inflammation. Chronic cases often show squamous metaplasia of the endocervical glandular epithelium. You might even find Nabathian cysts. Those are mucus-filled cysts from dilated glands.
So, chronic cervicitis can cause squamous metaplasia of the endocervix or even Nabathian cysts.
Now, moving on to infectious cervicitis. It can be caused by a wide range of organisms, things like gonococci, staphylococci, enterococci, Gardnerella vaginalis, Trichomonas vaginalis, Candida albicans, and Chlamydia trachomatis. That was a mouthful.
Whoa, that was for sure a mouthful. Looks like the cervix has quite the guest list. So then, how would infectious cervicitis typically present?
Interestingly, many patients are asymptomatic, but when they do have symptoms, they usually notice vaginal discharge or itching. And remember, the infection most often involves the endocervix.
Alright, let's then get into some specifics. How about we start with Candida?
Now let's picture a patient. She's pregnant, or maybe diabetic, or recently took a lot of antibiotics. She comes in complaining of intense vulvovaginal itching and thick white discharge.
Oh, it's that classic infamous curdy white discharge.
Exactly. That's Candidiasis, caused by Candida albicans. It's a normal component of the vaginal flora, but it overgrows under conditions like pregnancy, diabetes, immunosuppression, or after antibiotic use.
What would we see on cytology?
You'd see fungal colonies made of spores and branching pseudohyphae that are stuck on the cervical epithelium, plus lots and lots of chronic inflammatory cells.
Sounds uncomfortable for sure, but not dangerous unless it's complicated.
Spot on. Now, another case. I know you've been enjoying these. A woman comes in with greenish yellow, frothy vaginal discharge and complains of foul odor and painful urination.
Let me guess. Trichomoniasis?
Damn, Lina, you've got these in the bag. The key here is the greenish yellow, frothy vaginal discharge. This condition is caused by Trichomonas vaginalis, a unicellular flagellated protozoan. It's sexually transmitted and can involve both the vagina and the cervix.
And hear this amazing, interesting fact. You can actually see the organisms moving on a saline wet mount.
Yes, if you look under the microscope, you'll see motile trophozoites swimming around in a background of inflammatory cells. Next, woman who comes in with a mucopurulent discharge, a cervix that's reddened, congested, and edematous.
That's sounding suspiciously like chlamydia.
Exactly. Chlamydia trachomatis is the most common sexually transmitted infection in developed countries. It's an obligate intracellular, gram-negative pathogen, and it can coexist with Neisseria gonorrhea.
And it's important because of the complications, is that right?
Absolutely. Chlamydial infection can cause pelvic inflammatory disease and even lymphogranuloma venereum in some cases. That was a big word. However, chlamydia cervicitis is most often asymptomatic.
Alright, Malak, let's unravel the next case.
All right, Lina. Finally, we have a patient who presents with painful vesicles and ulcers involving the cervix, vagina, vulva, and perianal skin.
Ooh, I definitely know this one. It's herpes simplex virus type 2.
Exactly. Wow, Lina, you've been getting all of these correct. HSV2 is the culprit in most cases of genital herpes. It's spread through sexual contact and can cause ulcerative cervicitis.
So then, picture this. When we think of herpes, we think of painful vesicles and ulcers.
That's right.
Now, let's move on to the big one. Drum rolls. HPV.
Imagine a young woman, early 20s, sexually active, comes in for her first pap smear. She feels perfectly fine, but the smear shows cells with enlarged irregular nuclei and perinuclear halos.
Oh, those classic coliocytes.
Exactly. HPV infection is super common. Over 20 serotypes that infect the cervix. Some, like types 6 and 11, cause condylomas, or low-grade lesions. The serotypes 16 and above, aka types 16, 18, 31, 33, and 35, feels like we're counting endlessly, are the high-risk types that can cause high-grade dysplasia and cervical carcinoma.
Alright, I know we're not in math school, but we definitely have to remember these numbers. So then, type 6 and 11 are low grade, but from 16 and above is high grade. And what happens at the cellular level though?
HPV infects squamous epithelial cells and causes coilocytic atypia, characterized by nuclear enlargement, irregular nuclear membrane, hyperchromasia, and a perinuclear clearing, giving that halo effect. Pathologists really have us in a tongue twister.
They really do. They choose the most complicated names ever. But hey, we got them. And this sets the stage for carcinoma in situ, or CIN. Is that right?
Exactly. Depending on the type, HPV can cause condylomas in the squamous epithelium, which may be exophytic or even flat, and those are by HPV 6 and 11.
So the low-grade serotypes cause condylomas.
Or HPV may result in dysplasia, setting the stage for CIN as you said. Let's walk through the grades. CIN1 is mild dysplasia. Only the lower third of the epithelium shows pleomorphic cells, and this again is caused by those low-grade serotypes, 6 and 11 if you forgot. Now for CIN2, which is moderate dysplasia, the lower two-thirds of the epithelium are replaced by atypical cells. And finally, CIN3, which is the severe dysplasia or carcinoma in situ. This is where you see full thickness replacement, but without invasion into the stroma. This is the stage right before it invades and becomes a full-blown cancer, so it isn't cancer quite yet.
Okay, let me guess this one again. High-grade dysplasia is a result of high-risk HPV serotypes 16 and 18, or even moderate risk types 31, 33, and 35.
You are on a roll today.
I really seem to be. And it's important to note that not every case progresses to cancer, is that right?
Yeah, so some CIN1 lesions regress on their own, but the risk of progression to invasive carcinoma is much higher with CIN2 and 3, especially if linked to high-risk HPV types. CIN3 is severe dysplasia or carcinoma in situ. The entire thickness of the epithelium is replaced by abnormal cells. But crucially, there is no invasion through the basement membrane yet.
So, in simple, plain English, CIN3 is right on the edge. It's cancer in place, but hasn't broken out yet.
That's exactly why it's called carcinoma in situ. The moment it invades, it becomes a true carcinoma.
Alright, don't hate me, everyone, but I have another term to throw in. I always hear the term CIN and SIL used. Can you differentiate between them, please?
Of course, don't worry about it. CIN stands for cervical intraepithelial neoplasia, and it is the histological diagnosis that we see on a biopsy. On the other hand, SIL, or squamous intraepithelial lesion, is the cytologic diagnosis that we see on a pap smear.
So, in other words, CIN is from tissue biopsy, while SIL is from cytology in pap smears?
Yep, and they mirror each other in grading severity. Now, as we said, if CIN progresses, it becomes invasive cervical carcinoma. About 80% of cervical cancers are squamous cell carcinomas. The rest are adenocarcinomas, adenosquamous, or neuroendocrine tumors.
I'm curious though, where do these tumors usually develop?
Well, mostly in the transformation zone. They can be microscopic or grow into large exophytic masses. And they're graded based on differentiation, either well, moderately, or poorly differentiated, and staged based on how far they spread.
Alright, Malak, brace yourself. Can you walk us through the stages quickly?
Oh goodness, but of course. Stage 0 is carcinoma in situ. Stage 1 is confined to the cervix. Stage 2 is beyond the cervix, but not into the lower third of the vagina or pelvic wall. Stage 3 involves the pelvic wall and or the lower third of the vagina. And stage 4, finally, extends to adjacent organs or shows distant metastasis.
But then, what would the symptoms be as it progresses?
Well, early on, it can be completely asymptomatic. Later, you might see vaginal bleeding, postcoital bleeding, pelvic pain, weight loss, leg swelling, and in extreme cases, fistulas causing urine or feces leakage into the vagina.
You know, we've been talking a lot about the progression from HPV infection to CIN and then to carcinoma, but we're forgetting one important aspect here, or an important question that we forgot to ask. What exactly makes some women more vulnerable than others?
Great question. There are definitely important risk factors that increase the likelihood of developing CIN, SIL, and ultimately cervical cancer, and most of them are tied directly or indirectly to persistent high-risk HPV infection.
All right, Malak, you already know what's coming. Let's walk through them one by one.
First of all, an early age at the first intercourse is a major risk factor. The cervix in younger women, especially teenagers, has a more exposed transformation zone, making it more susceptible to HPV infection.
So basically, the earlier the sexual activity starts, the higher the risk for HPV infection.
That's right. Then, there's multiple sexual partners, which obviously increases the risk of exposure to HPV. Having a male partner with multiple previous sexual partners is another strong risk factor. It's really about cumulative HPV exposure.
And persistent infection by high-risk HPV types, especially 16 and 18, is the actual cause at the cellular level, right?
Right. Persistent high-risk HPV infections is the true driver behind the abnormal cell changes. That's why most cervical cancers show evidence of HPV DNA integrated into the host cells.
Any other factors besides sexual activity?
Yes, low socioeconomic status is another risk. That could reflect reduced access to regular pap smear screening, delayed diagnosis, and limited vaccination coverage. Multiple full-term pregnancies also slightly increase the risk, probably because pregnancy causes hormonal changes and exposes the cervical transformation zone for prolonged periods.
And ultimately, it all traces back to, you guessed it, HPV.
Exactly. HPV is the single most important cause of CIN, SIL, and cervical carcinoma. In fact, 85 to 90% of precancerous lesions show detectable HPV DNA, especially in high-risk types like 16, 18, 31, 33, 35, and the numbers just keep going up from there.
Whoa, that is a big percentage. No wonder HPV vaccination is emphasized upon so much.
Yeah, because without persistent HPV infection, the risk of developing significant cervical pathology is incredibly low. Thank God.
And that's also why pap screening is so important.
Exactly. It's a cytological exam of cervical cells stained with the Papa Nicolau stain. You have no idea how long it took me to pronounce that. It can detect squamous intraepithelial lesions long before any gross abnormality is visible.
You're right, Malak. Let's just stick to calling it a pap smear. Well, how often should women get screened?
Starting at age 21, every 3 years. After 30, if cytology is normal and HPV DNA is negative, screening can be every 5 years. Now, if HPV is positive but cytology is normal, repeat cytology every 6 to 12 months.
And if the pap test is abnormal?
Then we go for a colposcopic exam with biopsy. And let's not forget, HPV vaccination is a game changer. It's recommended for girls and boys, starting at ages 11 to 12 and catch-up vaccination up to age 26.
Does it cover HPV types 16 and 18?
Absolutely, because those two types account for about 70% of cervical cancers. Some vaccines also protect against the lower grade ones, 6 and 11, which cause genital warts. But even though the vaccine provides great protection, women should still continue regular pap screening because the vaccine doesn't cover every single oncogenic HPV type.
All right, I know we are discussing cervical disorders, but let's switch to neuro for a minute and get these brain cells to work by going through some practice questions.
Sure thing. Now I'm going to be the villain and ask the questions. Now, if a pap smear shows coilocytic atypia with nuclear enlargement, irregular membranes, hyperchromasia, and a perinuclear halo, what is the most likely infectious cause? The answer is HPV, human papilloma virus, especially type 16 and 18 for high-risk lesions.
Let's continue this villain role and get a clinical one. Let's see if you can catch it.
A 30-year-old woman with a history of multiple sexual partners presents for a routine pap smear. Cytology reveals high-grade squamous intraepithelial lesion, HSIL. Now, what's the next best step in her management? The correct answer is colposcopic examination with directed cervical biopsy. This is what we do when we find abnormal pap smears, like in this patient.
All right, listeners, this was definitely a ride. But before we wrap up, let's go through a quick recap of what we covered today. What do you say, Medic? Let's play hot potato?
Let's play hot potato. Now, we started with the cervical ectropion, also called erosion. That's when the delicate columnar epithelium of the endocervix extends outwards onto the ectocervix, giving a red, inflamed appearance. It's a benign finding, typically triggered by hormones, chronic irritation, or inflammation like cervicitis.
Following that, we discussed squamous metaplasia, where the body adapts by replacing columnar cells with tougher squamous cells at the transformation zone. Squamous metaplasia itself is benign, but it creates the environment where HPV infections can start. And that's where the story of dysplasia begins.
Then, we moved on to cervical polyps. small, soft, pedunculated growths, usually arising from the endocervix. They're benign inflammatory proliferations, not true neoplasms, and are made up of fibrous stroma covered either by squamous or columnar epithelium.
After that, we talked about cervicitis. We distinguished between non-infectious cervicitis caused by irritants like douches or tampons, and then infectious cervicitis caused by a variety of organisms like gonorrhea, chlamydia, trichomonas, candida, and HSV. You remember the list.
Now, for non-infectious cervicitis, the cervix appears red and swollen, and histology shows inflammatory infiltrates, like neutrophils, plasma cells, and lymphocytes, the gang. The chronic cases may develop squamous metaplasia and sometimes Nabothian cysts.
And for infectious cervicitis, we broke it down organism by organism.
First, Candida albicans causes thick, curdy white discharge and intense vulvovaginal pruritus, often seen in pregnant, diabetic, immunocompromised, or antibiotic-exposed patients.
Then, Trichomonas vaginalis presents with a greenish-yellow frothy vaginal discharge and foul odor, often accompanied by dysuria and dyspareunia, and you can catch those motile trophocytes on a saline wet mount.
We also have Chlamydia trachomatis, which is the most common sexually transmitted infection in developed countries. It can be completely asymptomatic or present as a mucopurulent discharge with cervical inflammation. It's also a major cause of pelvic inflammatory disease.
And finally, HSV2, herpes simplex virus type 2, causes painful vesicles and ulcers involving the cervix and the genital tract. Then we transitioned into HPV infection, which is central to cervical pathology.
HPV infection is incredibly common, with over 20 serotypes infecting the cervix. Low-risk types like 6 and 11 cause condylomas and mild dysplasia. High-risk types like 16, 18, 31, 33, and 35, you must have memorized them by now, can cause high-grade dysplasia and ultimately cancer.
Under the microscope, HPV infection creates coliocytes. You must remember those. But if you don't, those were squamous epithelial cells with nuclear enlargement, irregular nuclear membranes, hyperchromasia, and a perinuclear halo.
From there, we covered cervical intraepithelial neoplasia, aka CIN, the precancerous changes. CIN1 is mild dysplasia, with abnormal cells occupying the lower third of the epithelium, while CIN2 shows moderate dysplasia, involving the lower 2/3. CIN3, or carcinoma in situ, involves full thickness abnormality, but still no invasion past the basement membrane.
And if you were puzzled like me with all of the terms, we did clarify that CIN is the histological term, while SIL, or squamous intraepithelial lesion, is the cytological equivalent seen on Pap smear. Thank God it's the shortened name.
And we stressed that not all CIN progresses to cancer. CIN2 and 3, especially when tied to persistent high-risk HPV infection, have a much higher risk of progression.
After that, we discussed what happens when dysplasia crosses the basement membrane, and that's where cervical carcinoma comes in.
A whopping 80% of invasive cervical cancers are squamous cell carcinomas. These tumors usually arise at the transformation zone and may be microscopic at first, or grow into large, exophytic masses.
We also broke down the grading based on differentiation, well, moderate, or poorly differentiated. And then we discussed the stage, which is how far the tumor spreads.
And finally, we highlighted the absolute importance of Pap smear screening, using exfoliated cells stained with the Pap stain to detect SIL before it becomes invasive cancer.
And we closed by talking about the game-changing HPV vaccine, recommended for boys and girls starting at ages 11 to 12. It provides protection against the most oncogenic HPV types, but regular Pap screening is still necessary because the vaccine does not cover every cancer-causing strain. That's a wrap on our deep dive into the uterine cervix, from benign changes to full-blown carcinoma. Thanks for staying with us through the twists, turns, and squamous tales of pathology.
We hope this episode brought clarity, not cramps, making the cervix a little less mysterious and your knowledge a little more empowered. Make sure to follow PodBites so you're always in the loop when we go deeper. Until then, stay curious, stay kind. See you soon.